Okay, thank you very much. So I would argue that there's nothing controversial about risk-based surveillance because it's just essentially a refinement of what we're already doing. If you think about it, the reason why we're surveying patients with cirrhosis is because they are at higher risk. But it's just that our understanding of HCC risk in people with cirrhosis has evolved over time, particularly in the last 5 to 10 years. And we understand now that within a cohort, a population of people with cirrhosis, there are a variety, a diversity of risk profiles. So some in this cohort of patients from Scotland will have a very high risk of exceeding 3-year risk exceeding 10%, whereas others will have a very low risk that's not much higher than 0. And the recent EASL statement in part reflects this evolving understanding of HCC risk. EASL have now changed tack in terms of their surveillance guidelines and are now recommending risk-based surveillance, and they argue that this approach is going to help to reduce mortality from HCC, and they define risk-based surveillance as being the decision to screen and the surveillance interval and the surveillance test can be varied according to the patient's individualized risk of HCC. And there are various arguments in favor of adopting a risk-based surveillance approach. It can be seen to be a fairer system, more efficient, improves the cost effectiveness, and arguably will reduce HCC mortality on the basis that it's better to perform high-quality surveillance in a small group of people than poor-quality surveillance in a large group of people. So risk-based surveillance is gaining a lot of support. I think there's a lot of appetite for it, and as I say, it's really just a refinement of what we're already doing. But the real challenge is operationalizing risk-based surveillance. And there are 4 aspects of this that are really quite challenging to address. So firstly, what risk model should we be using? What threshold should we be using to determine surveillance decisions? How should we be taking into account other factors beyond HCC risk that influence surveillance benefit? And how do we evaluate it? But the most fundamental question is, what risk model should we be using? I mean, are there any risk models out there that are suitable for risk stratification? And this is what a question we tried to answer previously. So the acid test of model performance is external validation. So what is external validation? Well, it's testing the performance of your model in an independent data set that wasn't used to train your initial model, but not just any independent data set, but an independent data set that's representative of the population where you actually want to use the model. So that's what we did here with evaluating 6 different HCC risk models in patients with cirrhosis and cured hepatitis C. So quite a large cohort of more than 2,500 patients. And we found that the AMAP score performed the best of these 6 models. It performed the best in terms of discrimination, separating high and low risk patients, and also calibration as well. So ensuring good agreement between observed HCC risk and predicted HCC risk. But the real crunch question, so this is the performance of the AMAP score, and we can consider it to be a level of unbiased performance as it's been assessed through external validation. But the crunch question is whether this performance is good enough to be used in the clinic. And that is not an easy question to answer. You can argue, for example, that this level of discrimination is too low, and it should be higher if we're going to use this score in the clinic, you might argue that this calibration is not strong enough. We need to show good calibration within age group or within different gender groups. You might argue that the external validation dataset was too small and should have more than 2,500 patients, or you might argue that the definition of competing risks that we used wasn't the right one. But in any case, the issue that we need to remember is that if we're going to move forward, we need to decide and build a consensus around what minimum standards should be for a HCC risk score. Otherwise, we will always find some reason to say that this risk score isn't good enough or that risk score isn't good enough. And the bottom line is that we do not need our risk scores to be perfect. We just need them to be better than what we're already doing. And what we're doing at the moment is we're stratifying patients, risk-based stratification based on fibrosis score. And we know that fibrosis score is a very blunt tool to measure, fibrosis stage is a very blunt tool to measure HCC risk. So it just needs to be better than what we're already doing. But even if you suppose that we have identified a HCC risk model that we are happy with, we forget that our goal isn't actually to estimate individualized risk. Our real goal is to make a surveillance decision. And how do we convert a patient's individualized risk into a surveillance decision? That is a tricky area. And it would be wonderful if we lived in utopia and we had a perfect model. If that was the case, we would see all the people that weren't going to develop HCC, they would have a predicted risk of about 0, and everybody, the minority that were going to develop HCC, they would have a predicted risk of 1, and it would be very easy to separate these two groups out. But of course, we don't live in utopia, we live in the UK, in planet Earth. And the reality that we have to contend with is that there is substantial overlap between the individualized risk of the people that aren't going to develop HCC and the individualized risk of the people that will. And so there's no obvious risk threshold at which we can separate these two groups. And that means we have to make compromises. We have to make trade-offs. If we set that threshold too high, so for example here, the threshold set at 20%, that's going to be good insofar as we will end up surveying very few patients that aren't going to develop HCC. But the downside of that is that we will also miss a lot of HCC cases. If we set it too low, then it's going to be good insofar as we will identify most of the HCC cases, but we will also end up surveying a lot of patients that aren't going to develop HCC. So we need to come up with some trade-off here, and there's no black and white answer to this question. And alluding to what Ian has covered, we also need to recognize that HCC risk is just one factor that influences surveillance benefit. Surveillance benefit is also influenced by liver dysfunction, medical comorbidities, and older age. And as Ian has mentioned, the issue is that the risk of HCC is inversely associated with these factors. So if you are at higher risk of HCC, you are likely to have worse liver function, you're likely to have more comorbidities, and you're likely to be older. And those are all factors that limit your chance of receiving curative intent treatment. So there is a real danger with risk-based surveillance that we will simply end up identifying a lot of HCCs, but not have those HCCs translate into curative intent treatment. So we need to work out how we are going to take account of those other factors beyond just simply a patient's HCC risk. And of course, I started the talk by saying that there are lots of benefits of risk-based surveillance, putative benefits, one of which is that risk-based surveillance will reduce HCC mortality. But this, although this is very plausible, it is a hypothesis. And how do we evaluate whether whether risk-based surveillance is having the effect that we expect it is? Should we be thinking about carrying out an RCT in the UK to compare risk-based surveillance versus standard of care? Is that one way we could be evaluating risk-based surveillance and potentially leading the world in the evaluation of this approach? It's something we should possibly be thinking about. So I would argue that risk-based surveillance has real potential to improve surveillance. And as I say, it is really just a refinement of what we are already doing. But the challenge is very much how do we operationalize it? And essentially, to operationalize it, we have to answer some really challenging questions, such as what risk model do we use and what thresholds for clinical action, where should we set those? And these are not black and white questions. They're very difficult to answer. There's a level of subjectivity about them. And in my mind, the only way we can move forward in terms of answering these questions is to set up an advisory group, an expert advisory group that advises the NHS on these types of questions. Otherwise, we will not progress, and it will become, thinking about Tom Bird's slide, it will become a little bit Groundhog Day-ish. And this is just to say that I've been talking about risk-based surveillance as if it's in the future, but it's arguably something that we're already doing to an extent already, and that's what this excellent survey suggests is certainly the case. So the challenge of risk-based surveillance is that it's something that can be a double-edged sword in a way. It can help to improve patient outcomes, but also if it's being applied unequally, if some clinics are using one risk score and another clinic's using another, and there's variability in practice, then that can only serve to reinforce inequity. Okay, I'll stop there. Thank you very much.